So I do believe that the ROSALINE trial has a specificity that it's the one of the few trials that it's focused totally on lobular breast cancer. So this is a different kind of population. We know that it's 15% of the subset of all breast cancers, but we do know that it's a different entity, pathologically speaking and biologically speaking, and also clinically speaking. They do not respond the same way as all of the other breast cancers. So with this in mind, we believe that we were wondering what was the best strategy to find the endocrine partner for the neoadjuvant setting. We knew from the previous trials that endocrine therapy alone was not good enough. We tried with the CDK4/6 and we saw that in the NeoPAL or the NeoMonarch, but the path CR rates were really, really low. So biologically speaking, we understood that preclinical models had shown synthetic lethality between the ROS inhibition and the loss of E-cadherin, which is so frequent in lobular. We know that 90% of the lobular cancers do not express E-cadherin. So the CDH1 alteration and the ROS inhibition acts and the synthetic lethality. So there was a clinical and biological rationale for this. So we had seen in mouse models the use of Crizotinib and how it affected the tumor growth in these mouse models. So with this in mind, while we were developing the ROSALINE trial with the ROS inhibition, the ROLO trial was ongoing, also recruiting patients, but in the advanced setting. So in the ROLO trial, they used Crizotinib plus endocrine therapy. We believe that Entrectinib would be a different partner. So we knew from the lung cancer that it was a bit more potent than Crizotinib, and we thought it would be a good partner here to add to the endocrine therapy. So that was the rationale to go to neoadjuvant setting with endocrine therapy, letrozole in this case, and Entrectinib. It's good to note that in the premenopausal patients, we did letrozole plus the ovarian function suppression, which is, of course, a no-brainer. But here we believe that the partner endocrine therapy and Entrectinib would be the best combo for the targeted agents. And then we also believe that RCB, so residual cancer burden, would be a good endpoint. So we focused on RCB01, and we designed a Simon two-stage to assess the efficacy of this combo that I just described. So we did a Simon two-stage where the Simon stage 1 had a 3% to warrant further investigation to the second stage. And then in the second stage, we targeted a RCB01 rate of 15%. To then move on to a phase 3 trial. We can discuss, and we've seen Hope Rugo discuss this, and also Marlene Koch when she asked us questions in the follow-up and the Q&A of the ROSALINE presentation. What was the best target here for, and what was the best endpoint for the neoadjuvant setting? We were a bit too ambitious, and we saw Rebecca Dent say that to us, that we were a bit too ambitious with a target of 15%, but we did believe that the RCB would be a good endpoint in the neoadjuvant setting. We now know that most of the trials with RCB in lobular are not doing so good. So we focused on the overall response rate by MRI as secondary endpoint. And you can see here in our trial, we had a 49% in response in the evaluable population. So in future trials, we are considering that as the primary endpoint for lessons learned.